Hello, this is Barbara McLean and I'm here with you today for a quick look at the arterial blood gas. Now I want to make sure you understand this is a quick look and it's derived in order to help you at the bedside to understand the principles of what your patient is presenting with, but it certainly is not the end all and be all. And so to begin, we really are interested in having blood gas evaluation. When we look at the arterial side of blood gases, meaning we're drawing from the artery and utilizing that blood through a co-oximeter or through our I-stat, we are able to determine oxygenation, appropriateness of ventilation, and the acid-base status. Now, a venous blood gas, which is beyond what we're going to talk about today, actually gives us a much bigger view, and that can be quite important to us when we're talking about mechanical ventilation. That venous blood gas tells us much more about cellular respiration and the acid-base status. It's a way for us to evaluate whether you have an appropriate blood flow dynamic, and it also can guide us to an endpoint of resuscitation, either by looking at the difference or the change in carbon dioxide in the venous and arterial blood, or as an endpoint of resuscitation utilizing central venous or mixed venous blood gas analysis, known as SCVO2 or SVO2. Now again, for our purposes today, we won't be discussing the venous blood gas, but if you subscribe to this channel, you will get an update when I post a series on mixed venous or central venous blood gas. So excellent. Now, respiratory monitoring, as we consider and as we initiate that, we remember that if we're doing an arterial blood gas, we're going to have three basic goals: acid-base balance, oxygenation, and respiration, measured by your base deficit, your PAo2, and your PaCO2. And at the bedside, we always have a basic trend monitor by using our pulse oximeter on a finger where you must have good blood flow in order to read a signal. That signal, known as SP for pulse, SpO2, using the finger and a probe, measures the proportion of saturated and desaturated hemoglobin. Now, desaturated hemoglobin is the hemoglobin that's already released the oxygen to be dissolved in the arterial bed. But it is important to remember that when you put the pulse ox on the index finger and you can't get a reading, the most important issue is, do you have a pulsatile picture? If not, you should forget doing the other finger and move up to the ear or to the forehead for evaluation. You must have pulsatile blood flow in order to read SpO2. Now, we make some assumptions about this. If SpO2 is 90% or greater, we are going to assume that our patient has an appropriate oxygenation. So what are the normal SA or SpO2 readings? Remember, SaO2 will come from the blood gas lab or your I-stat, and SpO2 is from your pulse oximeter, and they are relatively the same measure. 97 to 100% sat, whip! We got great gas exchange in terms of oxygen. Now, we don't know about CO2 yet, but in terms of oxygen. 90 to 95% is a mild decrease, but acceptable. In the acute and critical care situation, anything less than 88% saturation is going to be considered an indicator of severe hypoxia, and we're going to be very concerned. Now, not all patients are the same. Many patients who have chronic lung disease, either obstructive or restrictive lung disease, may have differences in their saturation that they have accommodated to and acclimatized to, so it doesn't cause a significant severe imbalance for them. Now, I want to move to something that is quite important when we're talking about blood gas evaluation in the critical care unit. First of all, we always look at oxygenation in three ways. What did you breathe? That's your FiO2. What is your saturation? That's your SaO2 or SpO2. And what is dissolved? Dissolved is what exerts partial pressure, and that's what's going to be used by the cells. So FiO2, remember, if we're at room air 0.21, that means 21% of atmospheric pressure is oxygenated. Atmospheric pressure here in Georgia is 760 millimeters of mercury because we're at sea level. So when I'm on 21% FiO2, I'm actually breathing 159 millimeters of partial pressure oxygen. If I'm on 100% FiO2, I'm breathing 760 millimeters mercury of oxygen. That's a big difference, and it means I'm using more oxygen to deliver that oxygen through the lung and into the blood. Now, one of the important aspects in patients, particularly intubated patients, is to say how much oxygen am I giving them and how much is in the blood. And that is called the P2F ratio. The gas that is dissolved in the arterial blood exerting pressure is your PaO2, and it's compared to the FiO2, which is the fractional concentration of oxygen, and that's normally expressed as percent of barometric pressure. Okay, so one of the things that I'm always really in support of is that bedside nurses should be communicating to their providers not just PO2 and not just SaO2, but also the P2F ratio. So the way people refer to that is PaO2 to FiO2 or P2F or the PF ratio. There's lots of different terms. PaO2 divided by FiO2, and the FiO2 is in the decimal. In other words, if it's 100%, it's 1.0. If it's 50%, it's 0.50. Taking the PO2 on the top, on the numerator, and the denominator, the FiO2, you do basic division. Now you can see the example I put here, a patient with PaO2 of 78 on 100%, 1.0 oxygen, 78 divided by 1 is 78. Now I only put that there because it was easy for me to do, just to think about it, not have to do any more math. But what I want you to remember is that you and I have a normal P to F ratio of 300 or greater. If I was on 50% FiO2, my PaO2 would be close to 300 or 350. Now we never see that because we have sick patients. Once we intubate you and put you on FiO2, the correlation of the dissolved oxygen which is available, PaO2, divided by the FiO2 tells us how severe you are. We use it a lot for grading in ARDS, and you can see here this simple strategy. If the PO2 is less than 250 on greater than 40% FiO2, we're going to consider that a mild respiratory dysfunction, and that may also be considered mild acute respiratory distress syndrome. Less than 150 on 40% FiO2 with PEEP now added in, 5 of PEEP to open the lung, that will be considered a moderate acute respiratory distress. Less than 100 on an FiO2 of 40% or greater with 5 or greater of PEEP, meaning that the gas I'm giving the patient is not getting into the blood, we're going to consider that to be severe. Now these criteria are called the Berlin criteria, and you can also refer to the ARDSNet criteria. The ARDSNet criteria was the developer of the PF ratio and the discusser of the PF ratio in terms of how to stage oxygenation failure. Now once we've talked about oxygen, that's basically it. We look at your PO2, we look at your SO2, we look at your P to F ratio, and we can determine whether or not you have appropriate gas exchange in terms of oxygen. That's the simplest part of the arterial blood gas. So we look at that PaO2 and we remember that that's the dissolved oxygen that can be used by the cells. The purpose of the saturated hemoglobin is to always maintain the dissolved state, so saturated hemoglobin always affects your PaO2. But the actual dissolved oxygen is only 3% of the total oxygen in the blood. The majority of oxygen travels around bound to hemoglobin as the saturation, which is why we're so interested. Normal PaO2 is 80 to 100 millimeters of mercury at the sea level, and it will be lower at higher elevations because the atmospheric pressure has changed. Normal level for infants who are breathing room air around 40 to 70, so they have a much lower PaO2 and still are very normal. Older adults typically will not have higher PaO2s. They are usually 80 milligrams minus 1 millimeter of mercury for every year over the age of 60. So let's talk about me. I'm 68. That's 8 years over 60. I know it's hard to believe. I'm 68, 8 years over 60. And that means that I would normally have 80 minus 8, and my normal PaO2 could be 72. And I might be feeling really, really well and able to function quite normally, and hopefully cerebrally I'm well oxygenated. But if PaO2 is abnormally low, so in general we're going to say abnormally low is anything in an adult less than 70, unless you're 100 years old, in which case that will be normal. We're going to call an abnormally low PaO2 hypoxemia. At any age, no matter if you're a newborn or an elder patient, PaO2 lower than 40 represents a life-threatening situation, and it requires us as nurses to act quickly. So when we receive a blood gas analysis with that level PaO2, we need to get everybody on board, get the team to the bedside, and let's make some decisions. So that's it for oxygen. Now I want to talk about the presence of acid and base. And I'm going to call this the acid profile. So normally you think about respiratory acid as CO2, which is perfect, that's absolutely right. And you think about metabolic acid. Oh, wait, you actually probably don't think about metabolic acid. Metabolic acid is the hydrogen ion. So when we talk about metabolic acid, we refer to keto acid or lactic acid, but the actual metabolic acid is hydrogen ion, and hydrogen ion has a positive charge. So first, what we need to understand is how acid is produced. So first, acid is produced during metabolism and cellular respiration. So very important to appreciate, cells are producing acid. Both metabolic and respiratory acid are produced by the cells, transported as carbonic acid, and that's H2CO3. All acids carried as H2CO3. Tissue acids increase in altered metabolic states because you have an increased production and actual distribution of hydrogen ion. We see that in patients who are ketotic. We see it in patients who are hypoperfused. Patients who have hypermetabolic disorders at the cellular level, which is almost everyone who's critically ill. And then we also see the tissue acids that increase in tissue hypoxia. And that means anaerobic metabolism. And that production tends to be more carbon dioxide. So hydrogen ion and carbon dioxide combined in multiple levels actually produces carbonic acid. Carbonic acid is what is transmitted through the blood, presented to the lung, and presented to the kidney for regulation. So, first and foremost, cells produce both the metabolic acid hydrogen, often seen with ketosis and lactic acidosis, and also produce the respiratory acid CO2. Now, let's look to the right side of your screen and talk about regulation. The kidney regulates acid. It's a major component of kidney function. And anybody who's been to CRT class knows that my consideration is if I have refractory metabolic acidosis, I think it's a time to consider continuous renal replacement therapy. So we think about our kidney as the major regulator of volume and electrolytes and waste products. And we all talk about that and we completely appreciate and understand it. But the other thing is that the kidney excretes acid and it also conjugates hydrogen to carbon dioxide in multiple levels so that you yield bicarb. So our kidney excretes metabolic acid hydrogen and conjugates metabolic and respiratory acid, yielding bicarbonate. What a beautiful organ that kidney is. I love the kidney so much. I'd even marry it if it asked me, but it'd have to have a really big diamond. Now the lung is an acid regulator, and that is really important because carbonic acid, H2CO3, so there's 2 hydrogens, 1 carbon, 3 oxygens. As it's presented to the lungs, it dissociates into H2O, 1 hydrogen, 2 hydrogens and 1 oxygen, and leaves the product CO2, which is then blown off by the lung. So ventilation doesn't tell us about the production of CO2. It tells us about the ability to remove the carbon dioxide in order to maintain our patient's homeostatic state. How fabulous is that? The kidney and the lung work together, and they are intimately related in terms of acid-base regulation. But the one other place that we often don't think about when we talk about acid-base balance is that the cells also regulate acidosis. They regulate the pH. In the presence of high levels of metabolic acid, hydrogen, the cell will uptake the hydrogen and it will release potassium in exchange because there's only room enough for one big bunch of positively charged ions intracellularly. Now, normally the intracellular ion is potassium, but the cell will release potassium into the serum and take up the hydrogen in the presence of metabolic acidosis. Now, nowhere is that more evident than it is in a person who has DKA, who has profound ketoacidosis. Hydrogen goes into the cell, potassium comes out of the cell, and when we first look at that patient, they actually have significant and profound hyperkalemia. All right. So cells take up acid in a metabolic acid state and release acid in exchange for potassium in a metabolically alkalotic state. What that means is if my bicarb is high and my base is in excess, I'll always have a low potassium, no matter how much potassium I give, until I repair the alkalotic environment. In the metabolically acidotic state, my serum potassium will overestimate how much potassium I've lost from the cell. This is an incredible opportunity for us to have a better understanding of the effect of acidosis on our other electrolytes and, of course, on our homeostatic balance and our pH. So if we look at our arterial blood gas report, for pH, the normal pH is 7.35 to 7.45, but I'm going to talk about a perfect pH, which is 7.40. Normal CO2 is 35 to 45 millimeters of mercury. I'm going to talk about a perfect CO2 at 40. Normal PAo2 is about 110 minus 0.5 times your age. Bicarb, normally 22 to 26. Base, not really base excess, but base is -2 to +2. 0 is perfect. And of course, O2 sat, we'd like to see you above 90%, and we're worried when you're below 88%. All right, so remember what I just said. The easiest way for us to have just basic understanding, not doing Henderson-Hasselbalch equations and other critical correlations for really advanced blood gas propagation, just a simple method. CO2, pH, bicarb, which is also hydrogen ion, and the base. Perfect pH, 7.40. That's always in the center. Perfect CO2 is 40. Perfect bicarb is 24, which means your acid level is also perfect, your metabolic acid level. The range of CO2, 35 to 45, and the green reflects the alkaline side, and the red reflects the acid side. Bicarb, 22 to 26. The red reflecting the acid side and the green reflecting the alkaline side. And then in the middle, the range of your pH. Remember, perfect is 7.40. 7.35 means there's a presence of more acid. It may not be abnormal, but there's a little more acid in the blood. And 7.45 means there's a little less acid in the blood. May not be abnormal, just a variation of normalcy with just ups and downs that occur when you're sleeping or if you haven't urinated for a bit or whatever, something normal that causes variation in those acids. So I want to talk about 3 basic steps for a very basic interpretation. I mean basic. And how we solve this problem. So number 1, when we look at a blood gas, we always look at the pH. We want the pH to be perfect, 7.40. But whatever side of the pH that we find ourselves on, so 7.36, 7.45, 7.36 indicates a shift in acid-base, and I'm more acidotic. And 7.45 reflects an alkaline shift and a more alkaline. This may not be a problem, however. It can just be a normal variation, and the pH is always going up and down within that normal range with normal variation. A little slower breathing, a little higher CO2, a little lower pH. A little faster breathing, a little lower CO2, a little higher pH. But everything CO2, pH, bicarbonate base or base must be normal for that to be a normal variation. Now, if my pH is on the acid side and it is below range, that always, always, always means you've got a problem. It's on the acid side and below range. That means below 7.35. You've got a problem. Doesn't matter how hard your physiologic responses are occurring to try to compensate. If your pH is not in the range of normal, you are acute, and this is a severe problem. So remember, we're always looking at the pH because it tells us about the direction of the problem. If the pH is down but inside the range and something else is contributing acid, you have a problem. But if your pH is in range, you always know that problem's been compensated. So we're going to take a look at this in a few minutes as we look at some blood gases to make sure that we understand. pH should always be perfect. Range, 7.35 to 7.45. Anything below 7.40 means a little increase in acid. It could be a big increase in acid with compensation. But if it's outside of range, you have an acute problem and you're not compensated. And the terms we used to use, partially compensated and all of that, we don't say that anymore. We just say you're acute or you're chronic. Acute means you got a problem and your pH is out of range. Chronic means you got a problem and your pH is in range. Pretty simple and very straightforward. So excuse me for going backwards because I wanted to show that to you. Okay, so number 2 in problem solving, look at your pH with the PCO2 direction. If PCO2 is up, that means more acid in the blood and your pH will go down. So just as you see here, CO2 is 50 and the pH is 7.34. pH is down and outside of range, you've got a problem and you're not compensated. Doesn't matter how close you are to range, you're not compensated. Your CO2 is up, you have respiratory acidosis. CO2 up, pH down, respiratory acidosis. Now you can have respiratory acidosis as a standalone, but you could also have respiratory and metabolic acidosis, and we'll come to that a little later. If you have a respiratory acidosis, our question is always, is this acute or chronic? Acute means that you've had a significant change in pH and it is outside of range. Chronic means that despite respiratory acidosis, pH is within the normal range limits, and that means that it's compensated. All right. So now we move to step number 4. I said 3 basic steps, and it's 3 slides, but it's actually more steps. I'm so sorry. So number 4, looking at the pH and correlate that to the direction of the base, or if what you look at is bicarb. But for us, typically on our arterial blood gas, it's going to be base. Base in excess means increased buffer. Base in deficit means decreased buffer. Okay, so if base is down, that means you have decreased buffer. Now the reason you have decreased buffer is because the base has already combined with the metabolic acid trying to neutralize it. But there's just too much metabolic acid to buffer and you're in base deficit. Base deficit with a pH that's down is metabolic acidosis. So similar to this. Your base is -8. Don't call that a base excess of -8. That's a base deficit. Base deficit, -8 with a pH of 7.30, you have metabolic acidosis. When base is down, metabolic acid is up. When base is down, whoop, whoop, there you go. When base is down, metabolic acid is up. Now, is it acute or chronic? Acute means the pH is abnormal and it's outside of range. And chronic means despite a base deficit, the pH is within the normal limits. That means you have to have compensated. So again, we look at the pH, we look at the PaCO2, and we look at the base or bicarb. And base and bicarb will travel in the same direction. If base and bicarb are down, metabolic acid is up. So either you look at base or you look at bicarb, or you look at both, but they will travel in the same direction. All right, so I find this to be very helpful. This is a simple cartoon that I developed, so excuse me if the animation is not quite correct, but what I want you to remember is you're going to see here those black lines or yellow lines in either case, black or yellow lines that are describing normal hydrogen, metabolic acid, normal base, the buffer to metabolic acid, normal pH, and normal CO2. Okay, these are all normal as we're looking at them in this cartoon. In metabolic acidosis, the metabolic acid goes up. You're not measuring the metabolic, you're not measuring hydrogen ion. So what you use is the reflection of base. And see how the base has dropped from its yellow line? Base is down because metabolic acid is up. pH is down and your CO2 is still relatively normal, which means your pH is down and outside of range, your base is down, and your CO2 is normal. You have metabolic acidosis. Metabolic acidosis. You determine that by the pH direction. That's what tells you what kind of problem you have. And then what will happen naturally and very quickly, if the patient is capable, is they will immediately begin to rapidly breathe, increase their depth, and blow off CO2. So now you see the CO2 has gone down. We still have high metabolic acid and low base, but CO2 has gone down in order to blow off acid and return the pH back to normal. And see how the pH came back to the yellow line? pH back to normal. CO2 compensated for the metabolic acidosis, increasing depth and rate of breathing, regulating CO2 to make room for the metabolic acid hydrogen ion. All right, now quite the opposite occurs with respiratory acidosis. So you see your ventilation is poor, you're retaining CO2, your CO2 goes up, your pH is down, and your acid and base on the metabolic side are staying the same in this cartoon. Your pH is on the acid side, it's outside of the range of normal. Your CO2 is up and outside of the range of normal, and you don't have any compensation. So you have acute respiratory acidosis. Now this reaction takes more time. The respiratory compensation is very quick. Metabolic compensation is very slow, and it takes quite a bit of time. So now what you see is as my CO2 was up, as my CO2 was up causing respiratory acidosis, I now, if I have functional kidneys, I will excrete acid and I'll use that excess of CO2 to also bind hydrogen ion, making bicarbonate. So my base goes up. The base goes up, that compensates the pH in the presence of respiratory acidosis. Now, because this is a short talk, we're really going to talk about the two most important deficits that we see in our critical patients: metabolic acidosis and respiratory acidosis. Okay, so first three rules of ABG. Rule 1, got to know the pH. pH determines whether the primary disorder is on the acid side or the alkaline side. Rule number 2, you must know the PaCO2 as the respiratory acid and the base excess or deficit as representative of the metabolic side. And in rule number 3, you need to be sure that the data is consistent. In other words, you've seen it in a trend, As it looks absolute, you're seeing physiologic compensations that also tell you. So again, with ABG interpretation, start with the pH. Perfect pH 7.40, normal range 7.35 to 7.45. There can be a normal variant, meaning the pH might be 7.36 or 7.43, but everything else is in the range of normal, both the base and the CO2 in the range of normal. That is normal. If you are in the range, but you have one variant out of range, you have to determine what the problem is. So if the pH is less than 7.40, that's an acid problem. If the CO2 is 60 and the pH is 7.36, that's a respiratory acidosis. But because you're in the range of normal, it has to be compensated. So remember, anything below 7.35 is going to be considered acidemic. Anything higher than 7.45 is going to be considered alkalemic. Below 7.35 means the presence of acidosis. Higher than 7.45 is the absence of acid, which is alkalosis. And again, we remember our basic criteria. Always start with perfect. The first question is, pH perfect, yes or no? Up or down? Inside, outside range? And then you look the same questions for CO2 and your bicarb and your base. Okay. So I'm really concerned that we appreciate the clinical presentation of respiratory acidosis, which is pretty significant. With respiratory acidosis, we can have severe hypotension, although we usually will respond to the presence of external catecholamines like norepinephrine or epinephrine or neosynephrine. Also, because with respiratory acidosis, you might see some alteration in potassium mobilization, you can see some delay in cardiac conduction. Sometimes you'll have very significant peripheral vasodilation with weak thready pulse, tachycardia, warm flushed skin, dyspnea and hypoventilation with hypoxia, and oftentimes with respiratory acidosis, as you're retaining CO2, the cerebral vessels will engorge and you'll get a very significant headache. If we were measuring your ICP, that would be elevated. You can have seizures, altered mental status, changes in pupil response to light, twitching, change in level of consciousness. And all we need to do is look at your pH and your PaCO2 and then see the reflection also, of course, of serum hyperkalemia. Metabolic compensations for respiratory acidosis are really renal, right? There's the kidney function. Kidney eliminates the hydrogen ion and it binds the carbon dioxide with hydrogen, creating bicarb. Bicarb levels rise. The base is now in excess. And remember the role of the kidney, which is the metabolic compensator for respiratory acidosis. The only metabolic compensation that can occur is if you have good kidney function. And that is that the kidney will excrete acid and conjugate buffer. So by the way, if you have respiratory acidosis and acute kidney injury, you're really in trouble because you can't compensate for that. That's why those patients are so sick. Okay, so management of respiratory acidosis, most importantly, determine what the cause is and improve ventilation if possible. Have to have good pulmonary hygiene. You need a lot of mobility, turning, proning. All of those effects will help with respiratory acidosis. We want to provide adequate fluid intake because remember, hypoperfused cells will produce more acid and respiratory acid as well in an anaerobic environment. We're going to add the possibility of non-invasive ventilatory support, and we're going to treat your respiratory rate. And with mechanical ventilation and respiratory acidosis, we're going to adjust our settings of respiratory rate and tidal volume, and that actually is called the amount of ventilation that occurs per minute ventilation. And also, we're going to look at time for exhalation. How long are we allowing you to exhale? And remember, in patients who are CO2 retainers, time is of the essence. They have to have a lot of time for exhalation. So we have to deliver gas in really fast and allow them a lot of time to exhale to get rid of CO2. All right, so let's take a look at a blood gas now. pH is 7.36, CO2 is 65, bicarb is 35, and the base is in excess, somewhere around +9. Okay, so pH is normal. It's in the range of normal, but on the acid side. So the two questions, when your pH is in range, but on the acid or alkaline side, Is there a problem that's contributing acid? So I go to CO2. CO2 is 65. So first and foremost, is that perfect? No. Is it up or down? Up. Is it inside or outside range? Outside range. And my pH is down. So I have respiratory acidosis. But my pH is in the range of normal, which means I have to have had compensation, and the only compensation that can occur is metabolic. So pH 7.36, CO2 65, bicarb 35, base plus 10, plus 9. I have respiratory acidosis with compensation. And the only organ that can compensate for respiratory acidosis is the kidney. All right, now let's take a look at this one. pH is 7.33. So is that perfect? No. Is it up or down? Down. Inside or outside range? Outside. So we already know we've got a problem, and even if there's attempts for compensation, we are not compensated. Okay? So pH is 7.33. That's acid. I'm now looking for acidosis. So I look over at the CO2. The CO2 is 25, which is not perfect, down and outside of range, which means you're blowing off a lot of CO2, which is the respiratory acid. That is not the problem. Then I go over and I look at my bicarb and base. So my bicarb is 15, and my base is in deficit at around negative 11, which means the hydrogen ion is way up, the base is down, the bicarb is down. I have metabolic acidosis, and it's acute. I don't say, oh, they're trying to compensate. It doesn't matter how hard you try to compensate, you didn't compensate. Compensation means pH is in the range of normal. So this is uncompensated metabolic acidosis, which we actually call acute metabolic acidosis. Okay. Well, the effects of metabolic acidosis, that clinical presentation, profound hypotension, refractory to vasopressors, dysrhythmias, very significant vasodilation. The skin may be cold and clammy, but it may also be really warm to the touch, because the biggest issue with metabolic acidosis is you lose vascular tone. pH is low, bicarb is down, base is in deficit. You have very significant serum hyperkalemia and the kinds of changes that you can see in terms of depolarization related to that. Big, tall, tented T waves. And on your laboratory analysis, the anion gap, which looks at the balance of positive ions to negative ions. And the biggest positive ion that changes? Hydrogen. So when hydrogen ion goes up and your base goes down, you get a wide anion gap. Lots of problems with metabolic acidosis. Really is probably one of the most common things that happens in our critically ill patient. It's the most feared, the most awful, and we can do lots of band-aids like bicarb administration, etc. But we really have to figure out what the issue is. Is it ketosis? Is it lactic acidosis? Is it one of the other big four? So very important, and I'm so sorry because I thought I had big four here, so let me just remind you. Big four. Metabolic acidosis. Number 1, ketosis. Number 2, high chloride. Chloride is a buffer, but when it binds hydrogen, it's hydrogen plus chloride. So that doesn't actually make you better, it makes you worse, right? So number 1, ketosis. Number 2, high chloride. Number 3, acute kidney injury. Number 4, let me bring my hand down here so you can really see it. 1, 2, 3, 4. Number 4, very significant. Lactic acidosis. Ketosis, hyperchloremia, acute kidney injury, lactic acidosis. The big four. Repeat after me. Ketosis, hyperchloremia, acute kidney injury, lactic acidosis. And the only thing that needs a special lab is lactic acid, because everything else you can see on your chemistry. So I remind you, if you paid attention in the first series about decompensation, critical illness, and hemodynamics, you are always going to assume that tachypnea is a compensation response for metabolic acidosis, and you have an absolute responsibility to investigate and stand by your patient's side and advocate for them effectively and well. So here's the big four. pH for critical care. If base is in deficit and pH is less than perfect and your patient is breathing fast, you have 4 big questions and you need to answer them sooner rather than later. Ketosis, you'll look at your glucose. Acute kidney injury, you'll look at your creatinine on your chemistry. Hyperchloremia, you'll look at the chloride level. And if the answer to those first 3 is no, or not enough to cause the problem that I have, I'm going to assume it's lactic acidosis, and I'll send a lactate level. So what do you think? Here we look at a pH of 7.55, PaCO2 of 26, PO2 of 80, bicarb 29, and a base excess of 6. So start with the pH, 7.455. Perfect, up or down, inside or outside range. Not perfect, up and outside of range, which means it's on the alkaline side. So now you look over at your CO2. Your CO2 is not perfect, which is 40, and it's down, and it isn't inside range. You have respiratory alkalosis. Now you look over at your bicarb is 29, your base is 6. These are also a bit alkalotic, so indeed you have 2 causes of alkalosis, both respiratory and metabolic. Your oxygenation is okay, you're on room air, you're 52 years old, you're okay. You got a PO2 of 80, you're okay. But you have significant mixed respiratory and metabolic alkalosis. Now let's go to the next one. pH 7.25, PaCO2 56, PO2 80, still good, not going to talk about that anymore. Bicarb 15 and base deficit negative 10. Okay, pH is not perfect, down and outside range, so it's acidotic. CO2 is not perfect, up and outside of range, so it's respiratory acidosis. And then we look at our bicarb and our base. Both of them are down and outside of range. Because they're both down and outside of range, metabolic acid is up, respiratory acid is up, pH is down. You have mixed respiratory and metabolic acidosis. See how easy that is? Look at the next one. pH is 7.36, so we're not going to even talk about the O2 here. This is an older person on room air 78. They're looking great. pH 7.36, PaCO2 59, bicarb 34, base positive 8. So pH is down but inside range, which could be normal variation or a problem with compensation. CO2 is up and outside of range, so you absolutely have respiratory acidosis, but your pH is in the range of normal, which tells you that you absolutely have compensation. And if the problem is ventilation, then the only compensation that can occur is the kidney. And we look over, or we look at the metabolic side related to the kidney. Bicarb is 34, base is positive 8. You have compensated or chronic respiratory acidosis. Now we go down to the last one. pH 7.38, PaCO2 is 28, PO2 is 90, bicarb is 12, and base deficit is negative 13. pH, not perfect, but down, but inside range. So either a normal variation or an abnormality with compensation. I look at PaCO2, which is 28, not perfect, down and outside of range, which means I'm blowing off CO2, I'm blowing off the acid. My bicarb is 12 and my base is negative 13, so I have very significant metabolic acidosis. My metabolic acidosis has made my pH on the acid side, but I compensated by blowing off CO2. This is a short form, quick look at arterial blood gas. And I want to remind you about how important this is in your everyday practice, because it's the cornerstone of hemodynamic evaluation and the cornerstone of evaluating patients with shock. So we have to think quickly, we have to always apply our information in a really good advocacy manner, and never be afraid to have the wrong answer if you're working with somebody who can guide you, mentor you, and offer teachable moments around arterial blood gas. Thank you so much. Bye-bye for now.